Good morning, everybody. And hopefully, we'll have our other panelists join here in just a moment. Uh, I do want to say, as a follow-up to our previous panel, there was a request to have AMAC submit a one-pager on the bill that they're supporting, the physician pro bono bill. And Andy, if you could send that to me, I will post it on the website at free2care.org, and we'll have it on the newsroom so that people can disseminate the web link and be able to share that on social media as well. The website, again, is free2care.org. But I think that was a wonderful segue to talk about current legislation and what's going on in DC and various states. I think this conversation will focus more on what's happening at the federal level. There's a lot going on. We don't expect much to happen because of it being a divided Congress. Most of the healthcare work that has been happening has been due to the president in his actions through executive order, but there are a number of things that are presenting through the House, and again, the pro bono bill is one of them. And those are always good ones when you can get bipartisan support. Sometimes it's also bad, and we'll talk about that here shortly. Some of the things that we want to talk about, of course, the ones that we have, as a coalition, have come out and supported and opposed. HR 3594, which is the Healthcare Freedom Account bill. The coalition is in support of that. It expands, essentially, it really changes HSAs and makes them more usable. It doubles the contributions, and it decouples it from high deductible health plans. It really gives the consumer, or the individual, the ability to do more with their own money, which is always a good thing. We are vehemently opposed to HR 3708. I think Chad will talk about that. That's the Primary Care Enhancement Act of 2019. It's definitely a misnomer. It doesn't enhance it at all. And some of the big drug bills, we've got a drug pricing panel later on. I don't know if they'll talk about this, but they may. But HR 3, which is Nancy Pelosi's bill on drug pricing, that is a very concerning bill because it is an effort to cap not only federal programs, but the private market as well. It is a step towards single payer without saying it, which that is the biggest concern for me. And then the Prescription Drug Pricing Reduction Act of 2019, which is the Grassley-Wyden bill, and that has some problematic issues. And then, of course, the various executive orders, which there have been quite a few of those. But we're thankful to the administration for their effort and their interest in making healthcare more free and more patient-centric, which is a big motivation for us. With that being said, I'm going to allow each of our panelists to introduce themselves. We'll start with Dr. Savage and then go on to Marnie and then Mr. Cantor. So please tell us who you are and why you do what you do.
Well, thanks, David. My name is Dr. Chad Savage, and for those of you who don't know me, I'm a direct primary care doctor, and I'm the president of DPC Action. And actually, some of my colleagues were mentioned just in the last panel, and Kat Lindley, who's one of our board members, actually presented yesterday, Dr. Lee Gross, Dr. Josh Umber, Dr. Kim Korba, and we're basically a healthcare advocacy group, and we try to encourage legislation that's going to be supportive of free markets and direct primary care. And I'm into this for very obvious reasons as a direct primary care doctor. I've been doing this for about 4.5 years. Some of my colleagues even longer, and we've been swimming upstream against a system that is not conducive to free market and direct primary care in our system. So we're trying to look out and stay vigilant for bad actors who are trying to squeeze us out of the market. Did you want me, David, to go into specifically our concerns, or did you want me to hand that off to someone else then?
No, I'd absolutely like to have you talk about what it is that you're doing, the issues that you see, and then most importantly, give those that are watching this video the ability to act. Give them some homework that they can work on, calls to make, emails to make, and who to make them to. So we want to make this as educational and resource-based as possible.
Absolutely. So let me give a little bit of background. So the big battle that's going on right now, and those who are engaged in social media may have seen a lot of hubbub about this over the last week or two, is there's a bill right now that just came out of the Ways and Means Committee called 3708. And this is regarding HSAs. And on the surface, it purports to actually help us as direct primary care doctors. And there's been quite a bit of contention and schism that has developed in the DPC community, sadly, regarding this. Many well-intended people on both sides. But the long story short is HSAs, which all of you know are a fantastic savings modality, pre-tax contribution, pre-tax growth, and pre-tax use. It's better than an IRA. Can be used for almost any service in medical care, but there's been debate as to whether or not you can actually use it for direct primary care. And one of the reasons for that is that HSAs came into existence in the 2000s before direct primary care was even in existence. People have been using them without any recourse so far over the last 10 years. But in 2014, I believe it was, then IRS Commissioner Koskinen sent a letter to a senator saying that he did not believe that they could be used for DPC services. Now understand that that was not legislation, that was not regulation, and many people's complaint about regulation is it circumvents the legislative process and gives it, a fourth wing of government quite a bit of power. Well, this is beyond that. He even circumvented regulation and basically in a letter to another person, which is totally informal, created something that is being treated as though it is in fact law. So to try to clarify that, several years ago, there was an HR 365 that was introduced, and it was very short, very sweet, very simple. Basically said, yes, DPC is a qualified medical expense. It would have cleared it up. Unfortunately, it didn't pass that year. Last year, there was another bill that replaced it, and suddenly it came back, but not as the original 365. It came back with many, many qualifiers and stipulations, and there are people who try to explain those away, but nonetheless, was a very different beast than the original very good bill that came out, 365. That one never got out of committee, and now we see this year's version, which is largely unchanged from last year's HR 3708. And the concern is this bill looks like it actually may have some wheels and may actually clear through the House. So many people say, okay, well, the intent of this bill is to make HSAs, a DPC rather a qualified HSA expense, but there are so many stipulations in this bill that we actually feel that it is harmful and that there's probably not a big rush to get anything through, because in June of this last year, President Trump signed an executive order instructing the Treasury Department to create regulation that allows for DPC to become an HSA qualified expense. And that should be coming out within the next 4 to 6 weeks, as they had a 180-day time period to do so. So understand the original push to really get this as an HSA qualified expense, that time period, that may no longer be, given this executive order, such an urgent thing. And many compromises were being made in this bill with the belief that this had to be rushed through. We are also hearing word that a very good bill may be about to be released. So again, the indication to rush through a bad bill is just not there. So some of our concerns, and there are quite a few, if you look through the bill, and I don't want to get too nuanced and boring to people, but right off the bat, it says that an HSA can only be used for a fixed periodic payment. And for what that means for those who aren't familiar with DPC, so we're primarily a membership model. You pay every month. And many people talk about getting unlimited medical office visits. But in fact, if you look at the contracts of many DPC doctors, that's actually not true. Some are worded that way, but their legal experts have warned many DPC docs that we have to be careful about structuring them that way, because if you say you're going to provide unlimited medical visits, that actually it may be an impossibility to actually come through on that promise. So many will say something like, well, you're allowed up to 20, 25 visits a year under this contract, something that realistically they're not going to exhaust. But if they do, any fees above which, you would have a per visit fee. This bill specifically states that if you do that, you would not be able to use HSAs for those kind of offices, which is a decent share of the DPC practices out there right now. And people would have to go back, restructure their contracts, and perhaps make them in a way that's very unfavorable. It also offers the first cap on HSA use that's ever existed. It sets a ceiling for what you can charge as a direct primary care practice. As I understand it, does not allow balance billing above that, even if somebody wished. And the analogy on that, so some people hear that and go, oh, that's direct primary care doctors being greedy because they want to charge a higher rate. Understand there's something called the market, and the fact that people control these funds themselves, that is a much better regulator of the threshold of what these fees will go for than is ever any arbitrary governmental cutoff. So the analogy is if you had a surgery and you wanted to pay for it with your HSA, and the government were now to step in and say, okay, you can pay for that surgery up to $1,000. Anything above that you can't do, so therefore you can't use your HSA. So there's some real problems with that, and it's a bad precedent not only for DPC, but actually other medical services. The other thing is it also excludes specialists from engaging in these kind of arrangements. And that's actually really, really concerning. And people say, well, why are you worried? Because you're a direct primary care doc, that won't affect you. And that's true directly, it won't. But that doesn't mean that we should support something that's going to hurt other people just because it doesn't hurt us. The wording is specific and specifically states certain specialties and not others. The worry about this is now if a specialist should decide to do this type of arrangement, they would, to actually overcome this legislation, would have to go through likely a several-year process, hopefully with a lot of support, to get new legislation, including them under a kind of direct specialty care kind of arrangement. And it's not just that they actually specifically state this can only be done with certain specialties, which the omission of the others is actually very, very important and could really hurt any of our subspecialty colleagues who are trying to do these kind of models, perhaps some even on this call right now. So they really need to be aware that this bill could actually hurt their efforts. There's also a pharmacy exclusion indicating that if doctors were to dispense pharmaceuticals under that monthly membership, that would make them a non-qualified expense, which seems just kind of ridiculous. If you're trying to consumerize and incentivize novel, innovative practice models, you wouldn't start putting barriers to innovation. And it also, and people will say, okay, well, again, I have a pharmacy, I dispense to my patients, very inexpensive. We get for 21 cents, we can dispense a month of Norvasc to our patients. That's how inexpensive these kind of drugs are. So it really is tackling some of the problems that are structurally in the healthcare system right now. We in direct primary care are addressing a lot of the pharmaceutical cost issues. But we do charge the 21 cents above that. So people who are in support of this bill argue, well, that wouldn't affect that. However, if I do an injection, and almost all direct primary care doctors do this, where if I do a joint injection, it's 30 cents a steroid. It's a needle. The actual cost of doing an injection is actually quite small. And the hassle of billing it, tracking it, et cetera, is actually above any benefit we would ever hope to derive from undergoing that process. So it's best to not have that sort of restriction, because if you now do a joint injection and don't charge separately for the 30 cents of dexamethasone you injected or whatever steroid you choose, you are now again excluded from HSA participation. To continue to go down, there's a real worry, and this is really pertinent for HSAs. There's, not to get too nitty gritty, but there's a 213 in the IRS code and a 223. 223 is for health plans. 213s are for qualified medical expenses. This bill supposedly corrects the HSA issue under the 223 section of the IRS code. The reason this is a concern is that even though the people who are framing this are claiming that the intent is that this will resolve the HSA issue and allow HSAs to be used for DPC, once it goes to the regulatory agencies and once they start using this flawed wording to create actual regulation around this bill, God knows what they will come up with. And they could say, well, you're a secondary health plan because you're under a 223 of the IRS code. And what that means, to have an HSA and contribute to it, you have to have a primary insurance, a high deductible health plan. If you have a secondary insurance, a plan, you cannot contribute to an HSA. So if they categorize us as a plan, you can contribute to an HSA, but you will, you can use your HSA, but you can't contribute to it, which would totally defeat the purpose of having an HSA. Now, and there are other issues with this bill too. So the big schism is there have been really good people who've been out there trying to get this bill passed, and they've been working for years. And I think at each stage of the process, they've made little compromises, and they're trying to get good scores for CBO and things of that sort. And again, I don't mean to slander them, but AAFP, the American Academy of Family Physicians, I'm an internist, I'm not part of them, has come out in support of this bill. And one of the concerns is in their actual letter of support, they indicate what a great support they are for direct primary care, and they're also supporting HR 2774. Now, why is that related? Because the reason why is that bill actually goes in the opposite direction. It says, again, things, if you pull people on the street, it's going to pull really well. They said under high deductible health plan, we're going to force your insurance company to cover 2 primary care visits per year with no copays and outside of your deductible. So that sounds great. However, you think about what that actually does, that's forcing payments through the insurance company. You're washing those dollars through an insurance company, we're taking part of it. And in those situations, you make it very hard, again, to be a direct primary care doctor, to innovate. You're forcing it through the insurance mechanism, and you're going to kind of ensnare in servitude more doctors to insurance companies as things like direct primary care become more of a niche if you're forcing insurance-based payments. And people think, well, that's really taking it to the insurance companies. If you do that, that is not taking it to the insurance companies. They will increase the premium in excess of the cost of those visits to cover it, and then they'll be able to take a portion of that. So actually, it'll keep more money with the insurers.
Well, Dr. I wanted to jump in there real quickly, and I think everybody can see why I have members of your organization jump on calls when I talk to members and senators. I can say with great confidence that what you're hearing from Dr. Savage is more than what many of the lawmakers know. When we have spoken to them, what they have been told, and in fact, if you go to the Ways and Means Committee, where they took the voice vote to support this bill and pass it out of their committee onto to the general floor, which hasn't gotten there yet, they only discussed the caps. They only talked about having a set fee or a cap for that fee per individual and per family. There was no discussion about these very dangerous and detrimental exclusions that followed through. So when we reached out to members and senators, they didn't even know about the exclusions. And these are folks that may have co-sponsored in the House anyway. Some co-sponsors didn't even know about the exclusions. So don't assume that they've read the bill with the co-sponsor. Sad to say, but that's the case, and we've seen that firsthand with this particular bill.
Yeah, and not only just read the bill, but read it and understand the wide-ranging implications of it. You've got to think 2 or 3 steps down. What does this compromise mean? And a lot of times, mainly when you throw it to the regulatory agencies, it's not going to be very, very attractive once it goes through that whole process. And you're going to, fence in this burgeoning innovative model and new things that are going to emerge that patients may like even better than the current DPC practices, which are very popular with their patients, will never be able to be created because it'll bump up against some regulation that never understood the implications of its existence. So I don't want to hog up too much time. There are other, a couple other bills too that I wanted to mention if we have the time, but let's
leave those for after we've had the other presentations. Absolutely. And bring those up for sure. I appreciate that. Thank you, Dr. Savage. Marnie? Oh, we can't hear you. You must be on mute. Well, and we'll try to have more
on the left bottom of the screen. If you
we'll try to have more of these bills available on the website.
How's that?
Oh, there you are.
Am I live? Sorry.
Hi, welcome.
Well, hello from sunny Florida, where it's about to be 87 degrees. Sorry, Carl, in the 30-degree deer stand. Thank you for having me. Do you want me to just kick off a little bit with a little bit about AID and where we are on the executive orders?
Absolutely.
Okay. So for those of you who don't know, I'm the executive director of the Association of Independent Doctors. We're a national nonprofit trade association that, as it sounds, represents the interests of independent doctors, and worked really hard to preserve them and explain to the media, consumers, lawmakers about why stopping the consolidation in healthcare, and in particular letting doctors practice independent medicine without becoming corporate America, is really important for doctors and for patients. One thing that distinguishes us from a lot of the physician groups on this call is that we're not physician-led, and we think that's actually a strength. We were founded by 2 certified accountants in Winter Park, Florida, and a healthcare attorney. And they got together in 2013 and said, wow, this consolidation is really bad for America, and we're looking at this strictly from a business and financial aspect. And plus the accountants represent about 115 independent medical groups, and they were seeing firsthand the devastating effects that we're having when our own local association or health systems, we have Advent Health, which was formerly Florida Hospital, and Orlando Health, are both within a mile of each other, and we're the 26th largest metro, so we're Midland, but we have these giants in our community buying up medical groups, and they were seeing how taxes were coming out the tax rolls, and that was devastating the community, and how the office workers were losing their jobs, and the doctors were having to go to work and have to meet quotas and were burning out. So for all those reasons, they got together and said, hey, we really need to do something to help the independent doctors. They started the trade association in 2013. At the time, I was a health reporter. I was a senior health reporter at the Orlando Sentinel. I came out of the Los Angeles Times, which is a sister paper to the Sentinel. And I covered the story that they were starting this trade association, and one thing led to another. I became the executive director in 2014. So here we are. Some of you know that story. Some of you members are on the call, and I appreciate you. But we have a mission, and we've been driving in the same lane since we started. I'm really proud of the founders for having this vision. But I think everyone on this call, for the most part, will agree with here's what we do, and what we don't do is, there's a lot to be done. We work on stopping the consolidation between hospitals and medical groups because we think that drives up costs and burns out doctors and is bad for patients. We work for price transparency, which we'll talk about with regard to the executive order. We work to enforce antitrust laws, and our hope to stop the consolidation, and we have some connections with the FTC, and we've worked on them to shut down several mergers since we began. We would like to see the end of site neutrality, or we would like to see site neutrality and the end of inflated prices, reimbursements to hospitals, and reduced reimbursements to independent doctors, because we think that drives the consolidation. And finally, this is a big one, and we won't get into it on this call, maybe next year, David, but we would like to end the abuse of the tax exempt status by nonprofit hospitals. So 62% of the hospitals in our country are tax exempt and don't pay any property taxes at all and behave like for-profits. Their executives are getting multi-million-dollar salaries, and they're not really giving back the charitable care that they probably should be giving back once, the nuns are gone, but once upon a time, the nuns actually did charitable care in exchange for not paying taxes, and we think that is not happening as much as it should today. So with all that, that's who we are, and I've had the privilege since I took over in this position at having a seat at the table and trying to help doctors have a collective voice on the national stage. Doctors are really busy removing gallbladders and reading x-rays and delivering babies and fixing cataracts, and I can't do any of that, but I can communicate on their behalf. And so I've had the privilege of being on Capitol Hill many times and working with lawmakers and writing editorials and articles for the media, trying to communicate and patients understand what is going on and what they need to be concerned about. So that's sort of how we fin. We are nonpartisan. We don't side with anybody, but I have seen over my course of working in this position that we really need to work with who's ever in charge. And our administration just so happens to be in favor of what we all want. They had a big paper, a 114-page paper on reforming America's healthcare system through choice and competition. And when I read through that, and this was with Alex Azar and then our Secretary of Treasury Acosta and the Labor Secretary, they all came up with what we need to do to fix this. And it was right over the heart of the plate as far as we're concerned. It's about free market, it's about choice, it's about control, it's about transparency, it's about site neutrality. I was nodding my head vigorously. I've never been so excited about a government document in my life. So I thought, this administration really gets it. So what's standing between us and having those things happen? Well, it's Congress and special interests, as you probably know. So I worked with some people on getting the first executive order that we're going to talk about today, the transparency executive order, which President Trump signed on June 24th, and Dr. Savage referenced it in his call. That is, it's a really, really important first step in getting price transparency. And the hospitals, of course, don't want it. The insurance companies don't want it. And all those who are profiting from the opacity in our system don't want it. But we're trying really hard to work to get it. And what I think probably all of you on this call probably know this, but it's a huge obstacle. The special interests are paying an enormous amount of money. They're in the top 5 or 6 contributors to Congress every single year over year. They have $25-30 million that we know about, according to Open Secrets, and they're working really hard to shut these bills down, and they're being pretty successful. So the executive order that was signed, it goes into to get codified. From what I understand, and I've been trying, what we all need to do is work to observe the language changes when it starts saying real price transparency gets muddy to price estimates or prices. I want that, or what just patient owes. So the other side, opinion, the folks that we're up against would say, well, listen, I can have a baby in Boston for $5,000 hospital. How does an average help me? What I want to know is, where do I go to have the $5,000 birth vaginal delivery that also has the best outcome? So we want, obviously, outcome transparency as well as price transparency. Well, the other side doesn't really want that. They really want to keep all those cost estimates. And then they say, well, let's just talk about what the patient's out of pocket is. That's all, again, to protect how much they're making. No, we want complete price transparency. We want to know cash prices. And what I understand, according to an article yesterday that came out in the Wall Street Journal, is where we are on that, because it was supposed to be written into law by now, because the executive order was signed on June 24th, is that they are trying to hold the insurers accountable. It was one thing to ask the hospitals to produce all their prices, but they also want the insurers to produce theirs. And there's a lot of blowback about, well, that's, a violation of our right to free private trade and private contracts and all that. Well, the government would say, the administration would say, no, we think those prices need to be transparent. And then the other big argument is, well, it's just too much information, it's just too hard, and Americans don't care that much. When we do have price transparency, they don't even use it. Well, that's because the law that got passed in January that required hospitals to post their prices online are impossible to read. They're impenetrable. They're buried on page 42 of their websites, and they're of no use or value, really, because you can't even read the code. It's just difficult. So they have to be clear, accessible, and readily available. And then we think that patients will actually use them to shop and compare value and price. Of course, we know that will help independent doctors. That's what we're about. We're trying to see that patients can see, oh gosh, if I go to Dr. Jones, who's employed by the health system, or Dr. Brown, who's independent, I'm going to have a lot better care and have a lot more time with this doctor and a better outcome than if I go into this hospital system that's going to add facility fees and make sure that I stay within the health system and not necessarily go to the best provider. So that's important. We were discouraged by the fact that CMS tried to push site neutrality out this year. They tried to they pushed as far as they thought the law would allow them. So I guess I apologize if you all know some of this stuff, but CMS is not against site neutrality. They have been for it. Medicare would like to see site neutrality, and the Medicare Advisory Commission has been advising for site neutrality, the fact that a procedure should be reimbursed at the same price regardless of where it's performed, whether it's an independent doctor's office or a hospital outpatient setting. They've been for this all along.
I think we lost you, Marnie.
But advises Congress. Can you hear me?
Yeah, I think it's getting to be pretty bad as far as the in and out. I think we missed quite a bit of what you just said. But as far if I can try to recap the site neutrality, CMS is in favor of it. But there was and the rule from CMS only applied to E&M codes, only the physician encounter codes. But there was still a lawsuit that came from the hospital industry because they understood that that was going to be the first step and there would just be a slippery slope. And unfortunately, they won in court, which I hope that will come back again. And that's something that can be put into place or codified by Congress, because that is a big issue for patients and for physicians. And I hope that site neutrality gets more and more importance. With regards to transparency, it's a big issue. Texas Public Policy Foundation, for which I'm a director, we co-sponsored some research with the Galen Institute, and I can put that on the Free2Care website as well for you all to read. But that's we absolutely are supportive of Marnie, her organization, and patient rights advocate as well, to continue to push transparency, because if we don't know what we're buying or how much it is, how can we move forward and try to be good stewards? It's virtually impossible. So if there's was there anything else, Marnie? Let's see if the connectivity got a little bit better.
I'm sorry. I'm at a Winter Park Women's Club function. I'm squirreled away in the back office, so I apologize if the reception is shaky.
It's better now.
No, but what you just said, I mean, we really want that price transparency. We think if patients can know the price, they will actually use it. It may take a learning curve, and that's why some of the FOs are saying you can't, the patients don't have the information. Once we give it to them, they don't even use it. It's because they don't know how to use it. But look at how we shop for houses through Zillow. Look at how we shop for cars. We get Kelley Blue Book online. Look how we shop for any appliance. We go online, we get the data, and the health industry is saying, oh, there's just too much information. Look, we have Alexa, we have Uber, we have Google. They are crunching huge data sets of data every minute. It's in our hands, it's in our fingertips. Healthcare can't do this. It's not too hard. They just don't want to. So I don't think we are going to be able to work with this Congress based on how much money they're getting paid. They're not getting it from the independent doctors, but they're getting it from pharma, they're getting it from the insurance companies, they're getting it from the AHA, the AMA, all of them, all the people who want to, I call them the opacifiers, the people who want to maintain the status quo and maintain the gravy train. But we need to take that house of cards down with utter, complete, clear transparency with pricing. So, and then one other thing, David, if I have a few minutes, is the other executive order that was signed on October 3rd about the Medicare. And that was really a shot over the bow against Medicare for All. And I got a seat, thanks to our friends at Patient Rights Advocates, in the second row of that. It was at the Villages in Florida, and was able to watch President Trump deliver the speech, which was really impressive. And Seema Verma was sitting on stage, Alex Azar, a bunch of other folks. And he said a few really important things that day. And forgetting all the politicking, which was happening, sure, but if you get right down to it, what he was saying is that Medicare is for seniors, and that's where it's going to stay, and we're not going to dilute it by getting it all mired around the whole country. But there was a section in the bill that has gotten some doctors worried. Section number 5, and that was about leveling the provider, nurse practitioner, physician assistant, make them all equal in the eyes of the reimburser. And we don't like that at all. And so we believe at AID that doctors are doctors, and nurse practitioners and provider and nurse PAs are not. They shouldn't be paid the same amount. And the nurse practitioner and physician assistant should always be supervised by a doctor. So that's where we stand on that. However, we don't want to throw the baby out with the bathwater. There's a lot in this Medicare bill that's protective of seniors, that's protective of our free market. Frankly, they want choice, they want control, they want transparency. So I want to make sure we hang on to all that, and let's work within the system and within that executive order to not have that aspect of it, and continue to educate. We're all writing comments, which, by the way, I'm assured they'll read every one of them. Write the comments, get on the government website. And I've also learned, this is for folks who don't believe, but I've also learned that they're not allowed to take any information outside of what's commented on. So I met with one of the top officers at CMS recently, and he said, Marnie, if you write an article in Medical Economics that's really persuasive and convincing, we can't take that into consideration. It must come on the government website. So it's important to comment, folks, and use your invitation, use your links. Keep it short, tell them what you think, and they are listening. And I think that's encouraging, because our hope lies in the administration right now. It does not lie in Congress, my opinion. I hope that came through.
And I'll say this. Thank you very much, Marnie. If you don't think one or two people can make a difference, regarding the Section 5 of the executive order, Karen Gallagher, and who's a part of Physicians for Patients, Nikki Johnson, Dr. Johnson, who was just in the previous panel as the president of that group, they put out a petition, and it got nearly within a month, I think, got 25,000 signatures. Within a week, it had over 20,000, and it got the attention of the White House, and they were able to get on a call with senior advisors. You can make a difference, and that kind of action, that kind of work will get you noticed. And that's what we do here as the coalition as well. We uplift each other and support each other and get each other access, because everybody has their gifts and their resources, and we share that with each other. Thank you, Marnie. Jeff, are you still on the phone?
I am. I just have myself muted there.
All right. Well, tell us a little bit about yourself, Medibid, not Medibid, your organization, and how we can, what are you looking at, and what are you trying to achieve?
Sure. Thanks for having me today. This has been a fantastic event you put together here, I have to say, with some really super people I see both attending as well as participating. So that is pretty exciting. But it's also indicative of what I've been kind of preaching as part of the mantra of what we've been on to, is that the only way we're going to solve this whole dilemma is if we collectively fix it. We cannot look to government or legislators or third parties or other entities to make it happen. It's the individuals that are making up the actual reality of it, which are the consumers and the doctors. So this meeting is indicative of that. That's actually happening, because here we are banding together, whether we realize it or not. And then I've always said that the only way we're going to bring down this whole cartel, as it were, is by the death of 1,000 paper cuts. There's no sweeping legislation, as others have said, or anything that's going to make this happen. And frankly, you know, the sad part is the senior market is controlled by the government already with Medicare. And then, of course, they're trying to push it onto the balance of it. But we can't let the private side, the under 65 market, fall into any kind of government involvement whatsoever. If we kind of take a look at the, you know, the model of where we're trying to go, if we look at Atlas Shrugged as a prime example, you know, we need to change the people to change the legislative culture. And so that's what we're doing at yourfreedomhub.com, which is kind of the entity we've morphed into over time, is we're building that army of consumers, but that are free market oriented, that want cash price transparency, because they understand that, which is the way they are brought up in the current system. No one understands that there are prices. It's all about co-pays and, you know, what's my end of it. So they don't even understand it like they understand how cell phones work or gasoline prices work. And at the same time that we need to really get the outcomes out there as well, which we were just talking about a few minutes ago, for sure. So those are all really critical things. So we've kind of become kind of an intersection of a variety of things, because we start up being just a straight healthcare disruptor to try to drive the BUCAs and all those kind of organizations not out of business, but to create a good consumer-oriented side where we turn the person into a cash-paying and cash-shopping consumer, so that now that they have a tool, they can go to the Surgical Center of Oklahoma, or they can get medications from overseas, or a whole variety of things that they could suddenly do when they figure out that they're in the driver's seat. And not surprisingly, outcomes are better, quality's better, the consumer likes it better, they're getting better services, and in the end, it's all less money. And 100% of it bypasses government and conventional insurance. So it's training the consumer to want to look for the DPC, to want to kind of patronize these types of places. And then, you know, it's funny that you mentioned Galen. We also had started doing, you know, it's already been for a while, podcasts concerning free market practitioners and as well as innovators. So every week we have great people on that talk about what they're doing in their little wheelhouse. You know, like we had Dr. Paula Muto with UberDoc on just the other week and stuff like that. So it's all these little different things that I was just saying, all these individual organizations and all these innovative doctors and consumers and people that are concocting new apps and whatever. None of that can work if it's something that's quote unquote covered, then that's the end of it. That's the kiss of death the minute that that word is in the same sentence. And so that's really what we've been being this broader disruptor now across the entire health spectrum, because frankly, everybody, says, oh, I've bought my insurance and now my health is all handled. Really? Are you going to eat today? I guess your health is not being handled by that BUCA or whatever you think you've put in place. It's really just protecting your wallet from this jiggered health cartel that exists out there, when you really just, and then you're, like you said, they'll just raise prices or whatever. So you're just this unknowing shill, this useful idiot in the entire process. And that's really what we're all about, is becoming that water cooler where all the consumers can get together and find out about all this disruptive and interesting things that are beneficial to them, as well as for doctors and other organizations. So we're working, right, as an example, with the Republican Liberty Caucus and Liberty International and the Roads to Freedom Foundation and a whole array of national health federations. So all these different organizations that are pushing to kind of get to that consumer. But just like you were saying a minute ago, David, everybody's in their own little space. But how do we pull them all together, as it were? And so what you're doing is very good, because it's in like kind of that area where the doctors are kind of congregating, and some of these thought leader types and some of this legislative stuff that's happening. And we're kind of in a space where we're bringing even that larger sphere in there as well to network with you. Not that you're doing your thing over here and they're doing their thing over here, that we need to be all together. And so that's really like the rallying call, and the mission is for us to save ourselves.
Hey, Jeff?
Yes.
Oh, just wanted to make sure. Okay. Very good. Well, I appreciate that. Are there any particular bills that you're following? And this is a question to the general group. Can you tell the audience, how do you follow certain bills? How do you know when certain things are there, that they're moving through the process? There are so many bills, especially at the federal level, but for those that are interested in what's happening in their state, how do you wrap your arms around something as significant as this? And I'm happy to share what we do, but with you all as with people with day jobs that don't do this for a living like I do, how do you do it?
I follow David Blatt. sorry, Al. No, it's very hard. Unfortunately, you can make a full-time job easily watching this. So, watch the sites. I'm going to plug our own, but like DPC Action, like Gallon, like the others that are advocating for you, because they're spending an immense amount of time, in their own time and resources, tracking these things. And even in those, it's interesting in the policy circles how occasionally something will come through, and people who are incredibly connected and involved in this will be surprised. I didn't know that was there. So it's an immense challenge. But look to the organizations you trust that are really looking out for your best interests, and perhaps sign up for their newsletters and things of that sort.
I was going to say, this is Jeff Cantor commenting. That's a little bit of what we've been also building up in the background. We have a few initiatives that we're bringing out as a bit of an aggregator for some of that information, because you're exactly correct. If we know about this stuff, it's great, but we're very, minimal in having any impact. We need those consumers aligned. And so that's partially the idea of bringing this out to them as well, that they're cognizant of when, the AAPS makes a notice that this bill is taking place, so you should be calling your senators and so on. And so that's the other part of it. It's got to get out there, disseminated to the end user. And that's part of the way to track this stuff, is that we're keeping tabs on the broad array of this stuff just because we have to. And then also we do a lot of stuff in Washington as an example. We're going to be November 15th. There's a big opioid conference at the American College and Surgeons Center being held by the College of Healthcare Trustees that we're a participant in. And so we're, networking and stuff in DC and building some other conduits to be able to disseminate information, so the end user is getting up off the couch and making that phone call. And that's what's going to be critical to make any of these bills that we try to track here actually take place.
And Jeff, and we really appreciate all of you guys, with Chad and the group at DPC Action. You're empowering patients. Marnie and your organization, you're empowering physicians to be independent, and Jeff also empowering patients with My Freedom Hub. to be able to take charge of their healthcare needs, use their own money, and experience that freedom. Your organization is aptly named. Any other points that you might want to bring up? Or Marnie, how do you keep up? I wanted you to address that question as well. Oh, you're on mute.
One more time. David, what was that? I was typing about a question to Bob Campbell.
Oh, how do you keep up with what's going on at the federal level? How do you keep up with what bills that are out there that may be of importance to you, your organization, and the physicians you represent?
It's my network. It's you all and my doctors. My doctors bring me issues that are causing problems, like when they find out that Medicare is going to stop paying for a certain kind of PET scan in the cardiac lab and just shut them down. They're like, wait a minute, we need help there. So I read and I get a lot of stuff from my members and from my colleagues, such as you. I keep up with it and then try to keep my ear to the ground, and occasionally a lawmaker will bring something to my attention as well. So yeah. I just try it and I get out there.
Another question for the three of you. What particular sites do you visit? Congress.gov? Is there any other website? And feel free to share your own if you're staying up to date with those types of bills that would be of importance to physicians or people that are interested in healthcare in general. While you're thinking, I will say Congress.gov. If you go in there, you can set alerts. So if there's a particular word that you want to look for, you can put in your email and it'll send you any alert that will trigger whenever that word is in a bill.
And when you find that bill, David, also you look at it and you find one you're interested in, they have updates. So they'll send alerts once that it passes out of committee or something of that sort too. So that's all on that website as well.
Very good. All right. Well, we have some questions from the audience. Jeff, could you give the website for your organization, please? I've got somebody who's asking for that.
Sure, I'll give you that, and then a couple that I like to track as well. Ours is yourfreedomhub.com, and that's kind of still just a little bit under construction, so you'll see there's some links in there, but much will be added to that in short order. But that's a good beginning point. As far as sites to track for keeping tabs on stuff that's going on is the NHF.com, which that's the National Health Federation. They're the ones that sits at the Codex Alimentarius at The Hague and controls global food supplies. That's an important one. They have a lot of notices on what's going on that international level. And then AAPSonline.org, which is the Association of American Physicians and Surgeons, has a very good legislative feed on their site, and you can subscribe to that. And then the FMMA, the Free Market Medical Association, oftentimes has some good information. I mean, there's a wealth of them for sure. Like I said, we're tracking a lot, but those are some real high profile ones worth monitoring.
Very good. I appreciate that. Marnie, I'd like for you to address, there was a question, it alluded to this, but I wanted to flesh it out a little bit. Some have said that transparency isn't going to help. The argument that I get from a lot of other conservative groups is that we don't want government mandated transparency. There's the concern that, especially from those that would have a detrimental effect from having the transparency of the hospitals and the insurance companies, they've said, well, this will increase costs. We've heard all these arguments. How do you usually respond to that? And I'll leave that as our last question before we move on to the next panel, because I see some of the panelists starting to jump on.
Well, when patients have $8,000 deductibles and it's November, oops, can you hear me? And there's no way that they don't care about the price. So I think that patients need to know cash prices. I'm not saying we shouldn't have insurance paying for employees' health care. That's okay if they want to do that, but they really need to know what we're paying for, and employers need to know where their dollars are going. So that is just blowback. AHIP doesn't want it out there, and they are the ones that are saying it's just going to drive up prices when people see how low others go or how much more others are getting paid. it just doesn't work that way in a
Can
free
you,
market.
can you tell everybody what AHIP means, please?
Oh, American Health Insurance Plans. They're one of the special interests that really are, obviously they're speaking out on behalf of insurers who are resistant to exposing their prices and their negotiated prices. I understand that it's going to be there's going to be a pain point. It's going to be really hard for people, but I think once everything gets out in the open, sunlight helps everything. Everyone's going to be able to know what we're dealing with. When I go buy a car, I don't begrudge the fact that the dealer gets a profit. I just want to know what I'm dealing with here. What should this cost be before I drive the car home and then get the bill and it's non-negotiable and non-refundable. I think people need to have the information in hand, and I think Americans want that. In Ohio, there was a law, I don't know if you know this story, but there was a transparency law that was passed unanimously by legislature for price transparency. 100%. When does that happen? 100% of the legislators passed the transparency bill, and the government blocked it because special interests got in there, and it's all tied up in the court. So they're not getting it. The special interests really, really don't want these prices out there. And I'm sorry, there was a part 2 to your question. I got all fired up on that one. What was the second one?
It was, will transparency drive cost up and not down? That's also one of the arguments.
I disagree. I think in a competitive market, and patients can compare quality and outcomes. And there was a comment from one of the questions that I said outcomes a slippery slope. Doctors don't always have control of the outcomes. I do think in general, if you're looking at how the infection rate is or if the patients were happy, I think there is something to be said for that. I think everybody needs to be able to look at all of this with a grain of salt and take the information. Consumers are smarter than most lawmakers give them credit for, and be able to take the price information and the outcome information and how convenient it is and how much they like their provider and shop just like they do for a refrigerator. I think it's really important, and I do not think it will drive prices up at all.
Yeah, David, if I can even jump on that, it's a bizarre argument that they make. The argument, if extrapolated to other industries, would be, well, the best way to get a good price on a flat screen TV is to have no idea what you're spending on it. It's a very bizarre argument. And for people who claim that obscuration of the price will work, well, that's what we have right now, and we have the most costly healthcare system that has ever existed in the history of planet Earth. So it's clearly not working.
Well, Chad, we all know that you just go into Costco and slap your credit card down. We know you don't check price.
Well, when you're made of cash, what can you do?
Well, I was just going to say real fast on it. The reality is that the transparency does force the prices to reach their natural level, because you'll notice, like on a flat screen, there's a point where it doesn't get any cheaper. I mean, the market is figured out between itself trying to get to a cheaper price and those providing that service. This is as low as it can go that I'm still making a reasonable profit. It's all about that level of profit that they're making, that they're working on in the final analysis, because cost is cost regardless. So transparency is critical.
Let me say this just because we're short on time. And,
Sure.
and I think what you all have said is extremely valuable and a wonderful segue into our next panel discussion. I'm very pleased to have some good friends and industry leaders that will have demonstrated that transparency does lead to lower cost and oftentimes better quality. So guys, thank you so much for your time, your expertise, your passion, and the dedication that you give for patients and physicians every day.
Thanks, David.
Thank you all very much.
Thanks for having us.